ophthalmologist in the glamour city of Mumbai. He was previously the president of our association and the vice president of the Asian Venous Forum. He's currently the vice president of the International Union of Angiology and has a very good track record in academics and clinical fields. He's a pioneer of laser treatment of varicose veins in our country, and we are proud to have him as one of the leading members of our association. So over to you, Shoaib.
Thank you. Thank you, Harinder. Thanks very much for the introduction. Friends, welcome to this. Vishal, let's go to the Servier slide, please.
Yes,
Servier slide, please. So friends, today we are at one more webinar organized by the Venous Association of India. And at the very outset, let me thank Servier, which is known as Serdia in this country, an international pharmaceutical group. It has many brands which are all produced in India with no Chinese API. Our API is sourced from France. Serdia Pharmaceuticals has always been supporting Venous Association of India right from its inception. It's a major contributor to all our academic pursuits and including this particular series of webinars. It runs a series of social initiatives on Facebook directed to basically spreading the awareness about venous diseases to the lay population and to the physician population of this country. So first of all, thank you, Serdia, for everything that you do for us. So today we are going to, friends, talk about a condition called pelvic congestion syndrome. Now we all know that pelvic congestion syndrome covers a collection of symptoms and signs, both inside and outside the pelvis. There are many causes of this condition, including pelvic vein reflux. It is not surprising that most doctors and nurses still have difficulty in comprehending this condition. As pelvic congestion syndrome is made up of a diverse number of symptoms and signs, it is often ignored as a diagnosis by doctors. In fact, many gynecologists seem to ignore PCS, despite it appearing to be a major cause of chronic pelvic pain in women. Patients with vulval varicose veins following pregnancy are in fact often told that they will get better by themselves. And they fail to inform the patients that these varicosities may probably be linked to pelvic venous reflux. Not only that, even doctors who have some knowledge of PCS often think that the condition is restricted to females and do not diagnose PCS or PVR in males. Nowadays, however, with an increased understanding of the pathophysiology of the venous system, it has been found that these conditions are due to venous pathology in most PCS patients. Today, our expert speakers will take us and walk us through a path at the end of which we will all gather an understanding of this important area of phlebology, especially as far as the diagnosis and treatments are concerned. Today, we have two expert speakers with us today, Dr. Aleksandra from Poland and Dr. Tarun from India. To assist me with this webinar, I have the pleasure of the company of Dr. Tomasz Urbanek from Poland, who's our co-convener, who's very well known to all of us in India. Our expert panelists today are Dr. Mark Malou from Australia, Dr. Ahmed Gavish from Egypt, and Dr. Suat Dogansi from Turkey. We will introduce them in detail later. May I first introduce Dr. Urbanek to the audience. Dr. Tomasz Urbanek is a vascular surgeon from Medical University of Silesia in Katowice, Poland. I hope I pronounced that correctly. He's the current president of Polish Society of Phlebology. He's a member of European Board of Phlebology and many other societies all over the world. He's a member of the organizing committee of the EVF HOW program, to which quite a few of us have been, and the HOW Plus program. And we all know that he hosted the very, very successful midterm UIP meeting in Krakow, Poland last year in 2019. It's my pleasure now to hand over the proceedings to Dr. Urbanek, who will give his thoughts on this condition and then introduce the first speaker. Dr. Tomasz, over to you.
Thank you very much for this very kind introduction. To be honest, I thought that I will have an opportunity to see you in India this year, but due to Corona problems, this will be rather not possible, but hopefully once we'll see us in this wonderful place. Thank you Venous Association of India to invite us to this event. I think that right now, during this COVID time, we start to get even more international contacts, perhaps not in person, but we see a lot of friends in various parts of the world, and for sure, India is one of these places. But coming back to the topic, you mentioned about the pelvic congestion syndrome. I think that right now we should speak about something much more. This is in reality no more pelvic congestion syndrome. It's a pelvic venous disease or pelvic venous disorders. Our understanding of chronic venous disease in lower legs change our approach to many problems related to lower leg venous problems. Right now, the same happens regarding the venous pathology of pelvis, because we know that this is not only reflux. There are some obstructive changes. There are compensated, decompensated pathologies. My colleague Alex will speak about this soon. And I think that also understanding what we should do and what we can do needs some changes in our mind. And this is what you mentioned 2 minutes ago, that this is quite a long journey that we should pass through the pathology, understanding possibilities of treatment, because to put coils and to do sclerotherapy of the veins, it's probably not this what we should do in all the cases. And we should approach these patients in really individual way. We will not deal with the patient. I mean, we will not do the same with the patient with varicose veins related to the pelvis and with the patient with the pelvic symptoms. So I will not prolong this, and I would like to invite my colleague, my friend, Aleksandra Jaworucka-Kaczorowska. Dr. Aleksandra is a very special person. And one of the points that she's a very special person is that she's general surgeon certified. She's obstetrician and gynecologist, also certified with specialization. And she's also phlebologist, one of the best that we have in our country. So I think that such a combined unique experience coming from the three fields, and the main interest of Alex is of course phlebology, gives her the understanding of this process is much better and much wider than most of us. Like, I am vascular surgeon, you have various specialties, and Alex is coming from Poland, from the city that is called Gorzów Wielkopolski, and she's also the member of executive committee of the Polish Society of Phlebology. So I would like to ask Dr. Aleksandra Jaworucka-Kaczorowska to share the experience coming from the field of the pelvic venous disease. Probably this will be not only about the pelvic congestion syndrome, if we can call this still like this, but this will be also many other aspects related to this problem. Alex, welcome. So can we ask Aleksandra?
Yes, of course. Thank you very much. I don't know if you can hear me.
Yes, we can hear you.
So first of all, thank you very much for your invitation and for the perfect and beautiful introduction. Thank you, Tomasz, and thank you, everyone. I will talk about the basic anatomy and physiology of pelvic vein reflux. I have no conflict to disclosure. As you all know, pelvic vein circulation consists of 4 interconnected venous systems, which forms renal, pelvic, and leg reservoirs. 2 or 3 trunks form a single ovarian vein, which on the left side drain into the left renal vein, but on the right side into inferior vein cave, and in 10% to renal vein. The average diameter of this vein is about 5 millimeters. It drains from the internal genitalia above the cervix and form anastomosis with other visceral plexus in pelvis. There are a few possible variations in number of internal iliac vein. The most common is type 1, as you can see. In almost 50% of cases, it drains into the ipsilateral common iliac vein. It has several tributaries, and pudendal, obturator, and gluteal tributaries have their origin outside the pelvis. The pelvic venous incompetency may be because of the reflux in this vein, which I just said. It's usually primary incompetency, but it also may be secondary due to compression or post-thrombotic changes, and the incompetency of this vein may cause pelvic venous disorders. We have to remember that in the deep system, the number of valves increases from cranial to caudal, and the valves are only found in small and medium-sized veins. About 10% of internal iliac vein do not have valves at all. And in ovarian vein, they are mostly located in the distal third of the vein. And 15% of veins have no valve at the left side, and on the right side, 6% of veins doesn't have valves. So although 90% of patients have no valves in the internal iliac veins, not of course all patients will have, they will develop the pelvic venous disorders. And there are very little research into why women develop pelvic venous incompetency, and none of the studies have been replicated. One of the most important predisposing factors is, of course, pregnancy due to hormone influences and increased blood flow, increased capacity of ovarian vein, even up to 60 times during pregnancy, and of course, compression by enlarged uterus. And the incompetency may be also secondary due to outflow obstruction, which may be caused by the compression of, for example, left common internal vein against the lumbar spine by the right common internal artery. In most cases, this symptom is asymptomatic. In 2 to 5% of patients, it may cause obstructive lower extremity symptoms or other symptoms. There is also another possibility of secondary incompetency. It may be caused by the compression of the right renal vein. The most common is arterial compression between the aorta and mesenteric artery, but there is also a possibility of posterior and combined Nutcracker syndrome. This term should be limited only to patients who present with characteristic clinic symptoms and diagnostic imaging of the anatomy. There was analysis of reflux patterns, and according to this analysis, the reflux were mostly found in the left ovarian vein and right internal iliac vein. But as you can see, more than 50% have combined reflux. So we always have to check all these veins. Pelvic veins are connected together and also with the veins of the lower limb via the pelvic escaped points. When they are located on the pelvic floor, which you can see on the slide. So what are the symptoms of pelvic vein reflux? As I said before, most of the patients with the pelvic reflux are asymptomatic. And also the symptoms depends whether it is compensated or uncompensated reflux or obstruction. In case of uncompensated reflux, the patients usually have pelvic symptoms. In case of uncompensated obstruction, the symptoms are usually renal, in case of renal obstruction, or obstructive lower extremity symptoms in case of internal iliac vein obstruction. But the reflux may be compensated via the collaterals and may cause different symptoms. In case of compensated reflux, the reflux is compensated via pelvic escaped points and usually cause lower extremity and vulvar varicosity without pelvic symptoms. And obstruction may be also compensated via collaterals and cause pelvic symptoms and lower extremity or vulvar varicosities in case of incompetent pelvic escaped points. So we can have completely different clinical presentation of that pathology. I will focus mostly on pelvic symptoms, so pelvic congestion syndrome and lower extremity and vulvar varicosity of pelvic origin. And the most common pelvic symptom is chronic pelvic pain. It is the pain lasting for at least 6 months and associated with disability and required treatment. The prevalence of chronic pelvic pain is up to 43%, so a lot. But pelvic venous incompetency is responsible for up to 30% of chronic pelvic pain. We have to remember also about the differential diagnosis of chronic pelvic pain, so about the gynecological, gastrointestinal, and urinary problems. When the reflux is compensated via the pelvic escape points, it usually causes varicose veins of pelvic origin. They can be atypical lower extremity varicose veins, so non-saphenous distribution, typical saphenous truncal incompetency and related varicose veins, and also vulvar varicosities. We have to remember that among patients presenting in varicose veins of pelvic origin, less than 10% have been reported to have pelvic symptoms. Here you can see where these pelvic escape points are located. And based on the retrospective analysis of Sergio Genesini, the most common is peroneal point and inguinal point. Here you can see the peroneal escape points. We have 3 peroneal escape points: scrotal, intermediate labile point, and peroneal point. Here you can see the inguinal point, which is the second one. And sometimes there is also a possibility of gluteal escape point and sciatic escape point. So the atypical varicose veins of pelvic origin are estimated to be found in 3 to 4% of patients, but the prevalence may be even higher during pregnancy and in patients with persistent or recurrent varicose veins after previous treatment. Vulvar varicose veins are found in up to 10% of women, mostly during pregnancy, but they can also persist postpartum and enlarge with time. So how they appear? The reflux is transmitted via the internal pudendal vein to the external pudendal vein. And it can also be caused by the incompetency of the saphenofemoral junction or great saphenous vein, and then the reflux is transmitted to the external pudendal vein and perineal vein, and also superficial dorsal vein of clitoris. There is also a possibility of leakage from the epigastric vein from pelvis. The typical saphenous truncal incompetency may be also caused in the similar way. There is a possibility of leakage from the internal pudendal vein to the external pudendal vein and then to the great saphenous vein, but there is also a possibility of leakage via collaterals through the epigastric vein. So that's very important to perform duplex ultrasonography and visualize the saphenofemoral junction in each situation, because the incompetency of the saphenofemoral junction may be the reason for vulvar varicosities, but the competent saphenofemoral junction may suggest underlying pelvic venous incompetency. In case of suspicion of pelvic venous disorders, we should perform transvaginal or transabdominal ultrasonography. In transvaginal ultrasonography, first of all, we have to exclude other causes of chronic pelvic pain, which also can be a comorbidity. We can also confirm the presence of venous pathology. According to systematic review and meta-analysis, the occurrence of vein more than 5 millimeters crossing the uterine body and pelvic varicoceles seems to be the most indicative. In the transabdominal ultrasonography, we can visualize the ovarian vein, which diameter more than 6 millimeters and reveals caudal flow, has the positive predictive value. It also allows a visualization and assessment of iliac veins and renal veins. Cross-sectional imaging may also be helpful in the diagnostic of pelvic venous incompetency. The selective ovarian and internal iliac vein venography is a gold standard. It is essential before the embolization. It allows direct visualization and feeling of vulvovaginal and anti-varicosities, and also provide access for immediate endovenous intervention. In case of pelvic origin varicose veins, we always should perform transperineal ultrasonography to evaluate pelvic escape points. Here you can see the peroneal point, which is the most common, and inguinal point with the groin swelling and thigh varicosities. Pelvic venous disorders may also concern pregnancy. The most common are vulvar varicosities, which appear in second trimester of pregnancy. They can also vary obstetrician because of the possible rupture during the second stage of labor, and pelvic side wall and pudendal hematoma, but luckily they are a rare cause of massive bleeding. So I know that there are gynecologists with us, so should we perform the cesarean section? Unfortunately, there are no guidelines for organic cesarean section as a preventive measure. But of course, in case of large varicose veins, we have to be careful because the hemorrhage may occur, and the surgical hemostasis in that situation is very difficult to perform. What about the vaginal varicosities? They appear in less than 2% of women, but in case of large varicose veins, more than 1 centimeter in the vaginal wall, we should of course choose the special mode of delivery, usually cesarean section. Cervical varicose veins are also very important. We have to take care of this patient because of the risk of preterm delivery and severe maternal morbidity. There are also periuterine varicose veins, which can also spontaneously bleed because of increased venous pressure and may cause hypovolemic shock and even be the reason of patient death. It also concerns men. The most common is varicocele. It all mostly urologists take care of it, and especially in Poland. The prevalence is up to 15% in healthy men, but it increased approximately 10% for each decade of life. 2 to 10% have symptoms. Another is scrotal varicose veins. They are maybe caused usually because of the internal iliac vein incompetency and obturator and internal pudendal tributaries, but also saphenofemoral junction incompetency through the external pudendal vein may cause this pathology. They usually cause dull pain in the scrotal region and may be associated with angiokeratoma, which sometimes spontaneously bleed. According to the publications, 3% of males present the varicose veins of pelvic origin, and according to the studies, usually reflux in the internal iliac veins, not testicular veins, is the reason of this varicosities. I know that the next lecture will be about the treatment, but I would like to highlight only that we have to remember that most patients with pelvic venous incompetency are asymptomatic full pelvic symptoms and do not require any pelvic treatment at all. Of course, in case of pelvic symptoms, renal symptoms, or obstructive lower extremity symptoms, causal treatment should be performed, and embolization for pelvic symptoms has a very good results. It's effective method with 70 to 100% of improvement. In case of varicose veins of pelvic origin, most of the patients do not have pelvic symptoms, so they do not require pelvic treatment, and sclerotherapy from below our phlebectomy may be essential. Here you can see the external pudendal vein sclerotherapy and peroneal point sclerotherapy. And according to the literature, it has a very good therapeutic effect with low recurrence rate. And the results 3 months after the treatment. Another alternative is extricate point ligation and mini phlebectomy. In case of pudendal hypertrophy associated with varicose veins, we can treat it in one time, so we can do ligation and labioplasty. Scrotal varicose veins we treat in a similar way, usually foam sclerotherapy and the iliac laser has a very good results. In pregnancy, the treatment is mostly conservative. Interventional treatment should not be offered. It's only indicated in case of complications. And according to the studies, medical compression stockings has a beneficial effect on the diameter of vein and the reflux, but also relieves the symptoms and sign of chronic venous disease. Thank you for your attention.
Yes, thank you very much, Aleksandra, for this wonderful overview. I think that there will be discussion a little bit later on, but first we'll have some comments and questions from our guest and expert, unquestionable expert for me, Dr. Mark Maloof from Australia. If I may, I think all of you know Mark, but I would like to make short introduction. Mark is someone who is working with the phlebological patients already 35 years in Sydney, was trained in St. Mary Hospital in Paddington, London, and also in Sydney. And this, what is also very important, is the current president of Australian and New Zealand Society of Phlebology and past vice president of UIP, and also international board member of Venous Association of India, which you are aware about this for sure. And personally, I know Mark. It's a very friendly, very kind person, and also wonderful teacher with perfect understanding of the venous disease and problems related to its diagnostics and treatment. So we are looking forward for the question and comments from Mark. Mark, welcome to this wonderful meeting.
Thank you. Thank you, Thomas. That was most flattering, and I'm so pleased to be here. Alex, that was a really wonderful coverage of the anatomy and some of the treatment options. I enjoyed it because without that detailed knowledge, we can't make sense of this complex topic. So we needed that knowledge. I have a comment and I have a question. The comment relates to how to group these patients with pelvic venous disease. Firstly, there's the very large category that you made out, Alex, of pelvic varicose veins and no pelvic symptoms and no leg symptoms. And many of these people, the veins are found incidentally and need no treatment. The second group are the patients presenting usually to their gynecologist with primarily pelvic symptoms. And the gynecologists are coming around to believing that venous disease may well be the cause. The third group of patients with pelvic vein disease are our patients, our phlebology patients. They come to us because of leg veins. We pick up a history of pelvic vein story. We can see clinically escaped veins. And so we're the ones that say, now listen, this is coming from up the top. We need to image and find these pelvic veins. And so most of these patients come to us first. The three groups of doctors who write about this condition are us, the phlebologists, the gynecologists, and the interventional radiologists. But the only ones that really carry on with this treatment are us. So we've really got to be on top of this subject. The question. My question falls between the diagnostics, Alex, and what Taryn is going to talk about, treatments. In the past, discussions about the pathophysiology of pelvic venous disease were all about venous reflux only. We all came to believe that reflux involved left ovarian vein almost all the time, occasionally right and left internal iliacs, and we had to treat that reflux. And it was all about embolizing and coiling and injecting. But recently, and that was what you were calling, Alex, as primary pelvic vein reflux. But the secondary pelvic vein reflux due to obstruction is becoming much more observed, seen, looked for, and treated with stenting. And I think that the pendulum may be turning. So in your diagnostics, Alex, you didn't emphasize terribly much the you mentioned obstruction, but it's seeming to be coming more on people's minds. We've missed an obstruction. We've missed that left iliac vein problem or that renal vein problem at the top, and we really should be stenting as opposed to coiling. So the diagnostics determine the treatment options. So I just find that this may be turning. So once we've heard from Taryn, I would be very much interested to see, is this audience here thinking more about obstruction or just, look, this is a reflux problem and we need to coil it and inject it and sclerose it and that's it. So that's my question. How much are we turning towards obstruction rather than pure reflux? Thank you.
Mm-hmm. You know that most obstructions are asymptomatic, so you can find it in many, of course. Everything depends how you perform the diagnostics,
Yes.
because that's the most important thing. Sometimes the patient is lying, you can see the obstruction even if there is no obstruction. So we have to also remember about that. First of all, there are some obstructions, and as I said in my lecture, most of the obstruction, even found in the cadavers, so it was found in the studies in 24% of cadavers, they were asymptomatic. So we have to remember about that. According to the treatment, it's still controversial. Should we do coiling first or should we do stenting? I personally do not such procedures, but according to the literature, I think the best option is firstly do coiling, because the obstruction may be asymptomatic. If the symptoms do not disappear after the treatment, of course you can do stenting after that. Of course, if the stenosis is significant, we won't do coiling first. We will do the stenting, but everything depends on the patient. But I wouldn't agree that every patient with the stenosis should be stenting first. I would definitely go into coiling.
Alex, I think that just one short explanation. I think that the part of the question of Mark was, should we stop the diagnostics when we see the reflux? Because most of us will just see the refluxic veins, and should we always proceed with diagnostic to exclude the obstruction? Because it's quite easy if we have, you know, the lady which is after 3 pregnancies to find some veins incompetent, and if we have symptoms, everything seems to be clear. But do we have the evidence that we should always proceed for the imaging that will reveal the presence of the obstruction?
I agree with you that you have to always look for every vein. As I presented in the literature, 50% of patients do not have reflux in only one vein. So we always have to check each vein, and also if there is a stenosis. So the complete diagnostic before treatment should be performed. We cannot treat only one vein because it's possible that another vein also has reflux, and there is a possibility of stenosis as well.
Mark, any comments on it, or should we proceed to the next part?
No, one quick comment. I know that the cadaveric studies are interesting, but we're dealing more with patients that have come to us with symptoms and with disease. And the question in my mind is, how hard should we look for that stenosis before we say, let's coil? That's all.
Thank you very much. And we'll continue with next questions and comments coming from our next guest, Dr. Ahmed Gevesh, who is the consultant vascular surgeon from Egypt, and also academic senior lecturer at Aleksandra University, vice president from Egypt African Venous Lymphatic Association, and also member of UIP Engagement Working Group, a member of editorial board of Phlebology Journal, and also director of eVein clinics. Welcome, Ahmed, and we are looking forward for your comments and questions.
Thank you, Dr. Urbanek, for the kind introduction. Thank you, dear all Indo-Polish organizers, for inviting me. Dr. Alex, you made a great presentation, very nice overview for the pelvic venous disease, which come actually from a very experienced phlebologist with a great background, the ideal background for that topic. Obs and gynae and general surgery. So congratulations on that presentation. So you mentioned that in varicose veins of pelvic origin, that you rely on symptoms as your guidance for choosing whether you should treat the pelvic veins directly first, or you treat the veins directly. Actually, I have something I want to comment on. When you talk about the compensated venous pathology, we notice that that's a clinical notice that we all see, that when the veins dilate, you get less symptoms than the veins when they don't dilate. When you have big veins, that's usually less symptomatic than the small veins. That's the usual clinical finding. So I want to comment on how you mentioned using the terms compensated versus non-compensated and symptomatic and asymptomatic in this context, because obviously you can have a very large valval varicosity, still the patient is asymptomatic. So I think relying on symptoms on deciding whether to treat or not may not be ideal. That's the comment. And also when we investigate for the deep venous pathology and we find the obstructive lesion in the pelvis, and we do, for example, ablation of the greater venous vein, definitely we get not as good results when compared to patients who don't have outflow obstruction. And usually when we do bilateral ablations for patients having left May Turner, for example, the patient has very good symptom relief on the right side, but still he complains on the left side. So if you rely only on symptoms, I think that would not be, that would affect your results if you follow them up after a while. So Can you give us insight about this point?
Yeah, yes, of course. You know, I rely mostly on the literature. According to the literature, the treatment of, in case of you know, I was talking about asymptomatic patient for pelvic symptoms. Of course, when patient have a varicose veins of pelvic origin, I don't think we should perform the embolization first, because according to the literature, both systematic reviews and meta-analysis has shown that the results are not so good. Of course, we can, if you have recurrent varicose veins after the first treatment, you should perform of course, the coiling or stenting. But as the first treatment, the results hasn't proved that it gives a very good results. Even the recurrence rate was high when you performed stenting as well. So I'm not so happy about, you know, coiling everyone only because he has varicose veins of pelvic origin. Because if you, as from the other studies, if you do the treatment from below, the results may be really good, and patient doesn't have any pelvic symptoms. So why should we perform coiling or pelvic vein treatment?
Can I comment? I was talking about obstruction, not the coiling. I was actually I speaking about patients having iliac vein obstruction.
Yes, of course, if you have iliac vein obstruction and obstructive lower extremity symptoms, of course I will do stenting. But if you have obstruction and only small varicose veins on leg, do you think you should do stenting? I'm not so sure about that, because as I said before, there are lots of patients who are asymptomatic. Of course, the symptoms, the varicose veins may occur, but the treatment of these varicose veins may be efficient. You don't have to put stent only if you see the stenosis. Of course, if you have, you know, edema, it won't help only treatment from below. But if you have small varicose veins, vaginal varicose veins, for example, or lower extremity varicose vein, I definitely would go firstly to treat from below. If it won't help or it will have recurrency, I will do stenting.
Okay. Thank you.
Tomasz, you have to unmute.
You need to unmute.
Sorry, if you don't have any further comments, I will ask Dr. Padaria to continue
Thank you.
with the next part of the webinar.
Thank you. Thank you. First of all, let me thank Dr. Aleksandra. What a wonderful talk. And it just reinforces my view that this is such a complicated topic that discussions even on the basic anatomy and physiology and pathology can carry on and on. So this is a good topic that you chose, and you addressed it very, very well. Now, having laid the foundation of the basic pathology and the physiology, and having understood that, I think we can go to the next topic, and that is the interventions, the current interventional therapies which are available to us in this condition. And for that, we today have the pleasure of having with us Dr. Tarun Grover. Most of us on this platform know Dr. Grover. He is the Director of Peripheral Vascular and Endovascular Sciences at Medanta Hospital, Gurgaon, India. Medanta is one of the leading hospitals of the country, very well known in North India. Tarun himself is a dynamic personality with a unique privilege of having access to the latest modalities of treatment introduced in this country. He has been bestowed in the past the honor of first fellow in vascular endovascular surgery, accredited by the National Board of Examinations in this country. He runs a very, very popular vascular interventional course for postgraduates every year, and which is attended by hundreds of people throughout the country. Tarun, very kind of you to join us today, and we will look forward to your talk on interventions in pelvic venous disease.
Thank you so much, Dr. Shoaib, for such kind introduction. And I also enjoyed Dr. Aleksandra talk very much, and the itself, I would say, excellently elaborated that this pelvic congestion syndrome is a very complex disease, And the very fact we call it a syndrome because there are multiple symptoms which make this, I would say, the syndrome complex, because it's just not the pain, because depending on which part the reflux is affecting, whether it's affecting the bladder, whether it is affecting the bowel, whether it is affecting the rectum, patient can have various symptoms. And if the reflux goes down externally, then usually these patients, they do present with varicosities also. So we have understood the process, and now we will see what are the current methods of management of pelvic vein reflux. And as we know that PCS is caused by pooling of blood in the veins within the pelvis, which happens when there is a problem with the valves regulating the blood flow in the certain veins. We have seen that normally the flow is from the caudal part to the cranial end, which means the pelvic veins have to empty themselves in towards the heart. And if there is a valvular reflux and these veins are not able to empty themselves, then we would have significant reflux, pooling of blood in these pelvic organs, and these patients will have symptoms. And I would say the literature suggests that 30% of women, they experience it. And now the problem in India is a little different. What Professor Mark Maloof, he elaborated that a lot of patients, they come directly to him for symptoms. The difference in our practice is that most of these patients in India, they go to the gynecologist first, and somehow they are not counseled properly. I would say that they are told that probably these pelvic cramps and pelvic pains are just as a part of their menstrual cycle or hormonal imbalance. And there are very few, I would say, minuscule of population which is investigated further, or there are some, I would say, intelligent patient who look for their symptoms on net, and they read about pelvic congestion syndrome, and sometimes they themselves volunteer to get certain investigations done, and they are diagnosed to have this pelvic congestion syndrome. And so we have seen that majority of the veins in the pelvis, they can be involved in these symptoms. And I would say there are majorly 4 sets of veins which have to be thoroughly evaluated, which are the bilateral internal iliacs and bilateral gonadal, which means ovarian in females and testicular veins in males. And we must evaluate these veins if we feel these patients are suffering from pelvic congestion syndrome. And all these veins have to be thoroughly evaluated, because in case we are treating them, because literature suggests that post-treatment with endovascular procedures, the symptom relief is ranging from 5% to 90%. So you can imagine that the technique as well as how good you are in doing this procedure will ultimately decide that what is going to give relief to our patients. And in fact, most important is that we give the best result to our patients. And quickly, I'll just enumerate we have gone through these, that how to diagnose, but I would say that ultrasound duplex is definitely a gold standard investigation. The limitation of an CT and MR is because these investigations are carried out in a lying down position. And what happens is the moment these patients, they lie down, what happens is that the veins, they collapse, and sometimes the findings are fallacious unless until these are dilated to that extent that there are significant large, I would say, pelvic varicosities, internal varicosities, which are picked up, significantly large dilated ovarian vein. And there was significant discussion regarding the obstructive pathology, especially with the common iliac, either in May Thurner's or secondary to, I would say, a PTS, a post-thrombotic syndrome. In that case, IVUS does play a very important role. And definitely, I would say a good conventional venography will tell us all the areas which we have to deal if we are planning to intervene. And quickly, I'll just go through the transvaginal ultrasound, which is now considered gold standard. And I would say the correct way to perform a transvaginal is to have a special table where we can incline it to 45 degrees in, I would say, a reverse Trendelenburg position, so that we can have the veins, if they are having a good reflux, they can dilate, and a good Valsalva maneuver. You know, morphologically, we cannot make out the direction, but the change of color in these varicosities which we see during transvaginal ultrasound during a Valsalva maneuver will tell us that there is a reversal of flow, which is also an indicator of that there is a significant reflux present in these veins. So TD, MRV, and CT venography are objective investigations. I would say TVS is subjective because person should know what he has to look for. So in case you don't have a good operator who has given us all the desired information, the best is to do your ultrasound yourself, so you know exactly what we are dealing with. Because a lot of people, when they do the pelvic vein embolization, they do combine it on table with a transvaginal ultrasound as well, because in case they want to do sclerotherapy, transvulvar percutaneous sclerotherapy, so sometimes they can use the transvaginal ultrasound as well. And so this is the conventional venography which I was talking about. So sometimes, you know, there is a significant reflux, and sometimes you might have to tell the patient to do a Valsalva if you are doing, because we do these procedures mostly under local anesthesia, we have and some sedation. And if the patient is cooperative and we don't use sedation, then we can tell them to do a Valsalva, and we get the desired information that what sort of a reflux we are dealing with. Now, coming to my topic, which is the treatment options. So I would say that medical management is not treatment of choice, because by the time these patients, they are referred to us, they are having chronic pelvic pain, which is lasting them for months together, and they have not got relief from any sort of in medical management. And they are diagnosed. And so what we try to do is we try to develop a good rapport between our referring gynecologist as well as the patient, because sometimes these females, if they are suffering from dysmenorrhea or from pain during sexual intercourse, they might not be open enough to disclose their symptoms classically to us. So we have to have a good rapport so that we know what area, what exact symptoms they are having. It's just not that we have a diagnosis and we just jump on to the treatment. We must correlate their symptomatology to all the clinical findings as well as the diagnostic findings. So proper diagnosis is very important. I would say the open surgical and laparoscopic ligation of pelvic varices or doing a bypass, I have just heard it. Honestly, I'm not sure anybody is performing these. So ultimately, what we come to is either ovarian vein embolization, which is commonly, or a pelvic vein embolization, because I would say they're very there are significant number of patients who, apart from the ovarian vein reflux, they have involvement of other veins, especially the internal iliacs, leading to the pudendal veins as well as the obturator vein having reflux and coming down even externally to the vulval varicosities. So this is just an animation to show how we deal with pelvic vein embolization. So we have talked about this, that these are dilated veins, which because of the significant reflux, they dilate. And because of, if they have the extended reflux onto the external and superficial pudendal, they will have these varicosities around the vulval area. So a percutaneous technique means that we go in through the femoral vein, or we can go through the internal jugular vein as well. And then we go through the gonadal vein or the internal iliac using our catheters, then microcatheters. Then we will talk about what agents we can use to embolize these veins. And I have not included in my talk, especially the area where we are dealing with the obstructive pathologies, because and definitely that is a very important aspect. In case we are having an obstruction, that has to be dealt with. And once we deal with this reflux, we see these varicosities, they settle down, or they could be additionally treated with this external sclerosant, because once we have taken care of the major reflux in these patients. So the aim is occlusion as well as diversion, which means once we occlude the veins which are causing the reflux, there are significant large collaterals present in the pelvis. So basically it's a very complex collateral flow. So these veins will find some alternate path to drain back to the IVC or drain back to the heart, and these refluxing vein will definitely collapse, and the symptomatology of the patient will disappear. And now, what access you have to prefer, I would say it's primarily the cath lab orientation as well as the operator preference. If you have a mobile C-arm and a limited place, sometimes coming up from the jugular is limited. And I've seen some operating rooms where there is a limitation of these sort. But if, like, we do have a hybrid lab for these procedures, where you have plenty of space and you can shift your table and monitors in any direction. So what we do is, once we have evaluated, and if we feel that we have an extensive reflux, we do keep the jugular veins also prepped up, so in case they have to be used, otherwise we can come from the groin. Now, choice of embolic agents can vary from sclerosant and slurry of gel foam to coils, glues, and plugs, depending on whatever is available to you and what are you familiar with and what the anatomy or the morphology demands. Because the smaller coils, I would not suggest to be used in these areas, because initially there was, when the larger coils or the interlock coils were not available, people were using smaller coils. Because what happens is, when you put these smaller coils, and then sometimes the size discrepancy occurs when these patients they stand, and migration of these coils can occur. So if we are using a mechanical coils, in that has to be always supplemented with some sort of sclerosant and glue, or if these veins are very large, then we can use plugs also. Definitely we have to look for obstruction, and there we have talked about the most important is the Nutcracker syndrome, where the renal vein is compressed by the superior mesenteric artery. And if the patient is symptomatic because of Nutcracker syndrome, he's having hematuria, there are other symptoms also. Somehow there have been a lot of reports in literature that somehow endovascular options have not given good result in these areas, because eventually, because of the fatigue of the pulsating artery, the stents get fractured and they get rethrombosed. So with a good proven Nutcracker, I would say the first treatment option should be a surgical correction. But for a May-Thurner's, I would say now you have dedicated venous stents which do very well in this area. And so that can be used in case we are dealing with obstructive pathology. That has to be tackled simultaneously along with the pelvic venous reflux. And when we are dealing about the pelvic veins, this picture on the left shows you that, it again, depending on which area the reflux is happening, patient will have symptoms. So that would give us in the idea also that it's just not the ovarian or the gonadal vein which we have to target. And in my presentation, I've not included the embolization of varicose seal, because that's straight away the embolization of a gonadal vein. So we can take back the message once we see. So best would be to go through a prototype case which has got extensive reflux. And in this patient, you will see that the excess has been taken from the right femoral root. And this is the shoot from the ovarian vein, and you see there is a significant reflux. And so what you do is you do a selective run from ovarian vein. You see the early phase, you see the delayed phase, you see what pattern the veins are forming, and then selective DS, digital subtraction venogram, I would say, not an angiogram, should be also done from the iliac vein, and all the anatomy should be studied properly before we start embolizing. Now it's a matter of choice. If both veins are culprit on either side, either you can do ovarian vein first or you can use internal iliac vein first. There is no, I would say, there is any specific sequence in which you have to follow. Whatever you feel comfortable, you can start with that. And in this particular case, what we had done is we had gone for the internal iliac vein first. So here what you see is that I've taken excess from the right groin into the left internal iliac. And what you have to do is, first you have to start targeting the cross pelvic collaterals. Go as distal as possible so that you start going almost towards the midline and start targeting these collaterals. A good coaxial system should be used so that you have a good, I would say, a support catheter or the Judkins catheter or any other multi-purpose catheter, which gives you an access as far as possible. And through that, you can use a coaxial system with the micro catheter. So with the micro catheter, then you have the option of using 018 coils. And if you're using a large support catheter later, once you have done your coiling distally, then you can complete the proximal coiling through your 035 catheter using an 035 coil system. Now there are various coils, but somehow I would say the preference of coil in this area is the larger coils, something like an interlock which comes from Boston Scientific, as well as you can use the Cook coils like the Nestor, as well as the Hilal coils can be used. If you're using a micro catheter, these 018 coils can be used as distally as possible. So here you see from one side, we've gone absolutely distal, place these coils using a coaxial system, and further more coils, and all this while you see the micro catheter is in position. And so what you do is, because your micro catheter in its position, once you have placed the coils, then what you can do is you can use the liquid embolic, where that can be your STS, and you can use gel foam slurry also. So what these foreign material they do is they create significant inflammation in these veins and induce I would say thrombosis. So all these veins, they collapse and ultimately they cicatrize. In case you are, because there is significant reflux in these veins, if you are planning to use a liquid embolic, and which will be always most of the times used, I would say, if especially in a young patient who doesn't have any prior history of a surgery, and she has never been evaluated, then a good echo should always be performed to rule out any septal defects, because whatever you do, some amount of foam does go into the systemic circulation. You don't want a right to left shunt, especially in these patients. And other important area is when you are dealing with especially PTS patients, post-thrombotic syndrome patients. These patients, they do suffer from chronic smaller VTE, because VTE, which leads to pulmonary hypertension, and sometimes a subclinical foramen ovale can become clinically because of the right heart increased pressure can be a right to left shunt in these patients. So good echo should always be done in these patients, more especially in patients who are suffering from post-thrombotic syndrome, because venous hypertension, pulmonary hypertension has to be ruled out in these patients. And this is the embolic trap which is created. And you see now all the cross pelvic collaterals have been taken care of. And then you have the coils as well as the cast which has been formed. So glue you can use cetrol, so that you cause significant spasm of these veins, and then you can use glue in this area, and you have this cast. And further coiling as you are withdrawing your catheter back can be done. And these coils, the other advantage of these coils with interlock is that once you have introduced them, if you are not happy with the position, it is not something which your catheter has already left. You can always withdraw these coils back. You're happy with the position, you know where you want to pack them, and then you can always recapture them and pack and reposition them also. And the importance of these large coils is because they would range from diameter, they start from 4 to 6 and go up to 15, 16 millimeter in size, and with the length of almost close to 40 centimeter. So which means that these coils can take the shape of the vein in packing them, and gives you a very good result. So there you see that further coiling in this area, wherever you see the venous channels which are dilated, you can just pack them with your coils. And then back to the left ovarian vein, once you have dealt with the internal, because this patient had all the areas, so you have similarly what you have done is you have packed the ovarian vein, and then microcatheter use the embolic sclerosant in this area. And post liquid and embolic sclerosant, this sort of a picture you will find. And so you have to counsel all these patients that these patients initially would have increase in their pain as well. We do these procedures, we call them as a daycare, and depending on patients' pain threshold, sometimes these patients, they go back same day also, but we have to counsel them that some amount of fever, which is very common, low grade fever, post embolization syndrome is very common in these patients. And pain can persist for a week or 2 weeks in these patients. And then once you have completed one side, then you must complete on the other side also. And if you have a good descriptive investigation like a CT venogram, where you know where all your veins are coming off, otherwise sometimes if you miss these veins just from the groin, then engaging these veins or taking a good venogram from a jugular root is also important, because there could be a lot of variation. Especially on the right side, the gonadals can be coming off from the IVC, and some occasionally can be coming off even from the right renal vein as well in this area. And then you repeat the same process on the opposite side. And So these are some post-embolization images once you have done for the ovarian veins also. And though these images look that, there is a lot of foreign body inside, but these are, I would say these are platinum coils. These are very light and they hardly give any post-procedure, any sort of I have never come across any patient complaining of, these are absolutely inert. So they don't give any reaction or patient has had any problem with these. So this is pre and post embolization image. And
Tarun, we got about
yeah.
a minute or so left. Yeah,
Yeah.
Running out of time.
Yeah. So this is some other cases where this is one of my colleagues from US who had done these cases there. So that time large coils were not there. The smaller coils have been used. And this is the final case for description, where what difference we have used is, what we have done is we have inflated a balloon in the internal iliac as well as in the ovarian, so that you obstruct the drainage at that time, and then you can inject the sclerosant. And once you have a nice cast, so this can be also done. You can do a balloon occlusion if you have a very rapidly draining venous circuit. And large dilated veins, you can use a vascular plug as well. You don't need to use coils always. You can use a vascular plug, and this is the final result. And on table, you can do a transvaginal ultrasound. You can see these hypervascularity and these varicosities will disappear post embolization immediately. And this is my last slide. So I would say the success rate of pelvic vein embolization is reasonably very good, but it all depends on the clinical success, which varies fast from 50 to 90%. So I would say a correct diagnosis and evaluation and correlation with symptomatology and what patient is exactly suffering from is very important, whether it's purely cosmetic for the external veins, whether she's having pain, what are her exact symptom. It's a reasonably very safe procedure, and most of I would say the learning for the registrars for deployment of coils is done in these procedure, because you can rarely go wrong in this area, and a lot of coils have to be deployed. And in properly selected and screened patients, a transvenous embolization is safe and effective treatment for pelvic venous reflux. And so I would say this is a reasonably safe procedure and it can be done, but a good evaluation is very important. Thank you so much.
Tarun, first of all, congratulations for a lovely lecture. I mean, this just showed us your level of expertise and the type of patients that you do at your center. And I guess a lot of learning is to be had by all of us. I'll now take the opportunity of introducing Dr. Suat Duganki. All of us know about Dr. Suat. We all know him as a professor of venous surgery. He's from the Health Sciences University in Ankara in Turkey. He's director of Aerospaces Medicine, Health Sciences University. He's a member of UIP Scientific Committee. He's an editor of the Turkish Journal of Vascular Surgery and executive board member of the Turkish Society of Phlebology. Apart from that, Dr. Suat Duganki has a great interest especially in pelvic vein disease and in interventions in deep vein disease. He frequently talks nationally and internationally. He has published a lot of papers. He's an established expert in this field. And most importantly, he's a friend of the Venous Association of India. It's really a great pleasure to have Dr. Suat with us once again. And Dr. Suat, let us have your views and comments on Dr. Tarun Grover's lecture and what you have to say about it. Dr. Suat, over to you.
Dear Shuaib, thank you very much for this very kind introduction and your frank comments. And I'm really proud of to be a good friend of Indian colleagues. So, and regarding with the Tarun's presentation, as always, it was a perfect presentation in which in details he explained all the treatment of pelvic venous problems. The only thing that I want to comment, especially related with also with the previous lecture, is especially related with the compression syndrome. The idea of looking for truly all the possible reasons of pelvic venous disorders, we should always not just focus on the reflux, but we should also focus on the compression as well. But as all colleagues explained, there is no clear-cut definition of what is a real May-Turner syndrome or what is a real Nutcracker syndrome. There is, most of the definitions are subjective criteria. That's why we should, if we are fully agree that there is a real compression, that at this time, I think we should focus on treating the compressions first instead of treating the reflux, because in one of our study that we, this is not a published data yet, but we are finished the study. The first collateral which dilates in such a, even in a post-thrombotic situation or in a compression syndrome is the ovaric veins. So they are important collaterals. So they dilate to compensate the flow through the lower leg in such a compression syndrome, even in a post-thrombotic patients. If you coil such an important collateral, then the patient's symptoms increase afterwards. That's why it's highly important to detect if this is a collateral or not, especially in many patients on compression syndrome. When you approach from the right side, you miss the May-Turner syndrome because you go through the right iliac vein and even do your selective ovarian venography. You don't see the, especially the compression point of the left side. That's why this is really important to look for truly all those patients to analyze what is the underlying pathology. And second, related with the Tarun's presentations, it was a really perfect presentation. He already mentioned about a lot of issues, but the one thing is I also focus on that we didn't mention about the diameter of ovarian vein, because in many, let's say, instances, just looking for the diameter of the vein, an ovaric vein is accepted as a pathologic vein. But when we look at the literature, we know that even the small vein can have a reflux, but the larger vein doesn't have a reflux. So the diameter of the vein is not a criteria to decide a pathology related with the ovaric vein. And we should just look if it is a refluxing vein or not. That's why dynamic analysis of this pathology is important. That's why we have to look for a dynamic duplex ultrasound procedures for these patients. And regarding with the Tarun's presentation, which says that a transvaginal duplex ultrasonography is a gold standard, I think I have some hesitations because of it. Because when you do the transvaginal duplex ultrasonography, you miss the proximal parts of the vein. So you are not able to look for the compression points, and you cannot get the full ovaric vein or with the transvaginal duplex ultrasonography, because you should, I think, combine both techniques. This is very important. And also, you know that transvaginal duplex ultrasonography is also related with the consented women, when some women maybe may not give consent to have such a procedure. That's why I think we should also be more dependent maybe on transduplex ultrasonography. And the other issue, although you mentioned, and this is my question, you give some parts during your presentation, but could you please more comment on the complications of pelvic venous treatment? And you said that you can even use a lot of options like the embolic liquids or glue or whatever you do. But I think there are some also specific complications related with the used therapy. And I would be happy if you could give more comment on the complications after therapies, because as we all know that there is no therapy without a complication or without a problem. And our colleagues should also learn there can be some unwanted happenings after any therapy. Thank you.
Thank you so much, Dr. Swat. And I fully agree. You know, if anybody says that he doesn't have any complications, so my boss used to say either he's telling a lie or he doesn't do enough work. So definitely, you know, you do see complications when you do these procedures, but it's relatively a safe procedure. So I would say the most important thing any person who's starting this procedure is, especially if we go one by one, if they are using glue, then the amount of lipidol used with glue is very important, because I've seen people, they do aggressive use of Cetrol as well as lipidol and glue. This combination has resulted in patients suffering from acute renal failure, especially in young adults. And because the viscosity and the systemic transmission of STS along with lipidol, it affects the renal parenchyma, and it leads to acute renal failure because of the vasospasm in the renal vasculature. And local, I would say, usually when you're doing this procedure, it's a good thing to take a history that patient is not allergic, and you have to rule out all the, I discussed regarding ruling out all the cardiac anomalies, because if you're using a sclerosant, and coil migration is a possibility. We have seen we have a lot of blogs are there online regarding, because a lot of patients, when they come to us, they have read about these blogs that there is talk about coil migration. But again, a proper sizing and large coils, especially the length of the coil, is also very important. And if you can use coils which are interlocked, which you have a better control, so there is no migration of these coils. And again, like proper evaluation, like you said, that we should never intervene because if these veins are being the alternative channels to drain, like something, we don't do varicose vein surgery or ablation for patients who suffer from deep venous thrombosis, because the superficial veins are the alternative circuit. So similarly in the pelvis also, if we, especially we are dealing with patients who are suffering from post-thrombotic syndrome, which have I would say cross pelvic collaterals. In that case, we have to study our images very well so that we don't intervene in these patients. And so that's what we follow in our unit, because these patients are not primary patients who will walk into our outpatient and tell us that they are suffering from these particular problems. They are referred to us. So if we just, we always make a principle, we never rely on whatever the referral notes or the investigations or the advice which has been, or sometimes, you know, these females, they just walk into our outpatient and say, we have come for pelvic vein embolization. So I said, please let us evaluate you, that what exactly is the pathology, and then we should go through. Apart from this, I can't think of, honestly, because if you've done these procedures properly, and because ultrasound guided puncture you have taken, so local site complications honestly are unheard of, because these are venous excesses. And post compression, like I have not come across anybody developing any sort of, theoretical possibilities are somebody developing a thrombosis if you are given too extensive compression in the limb post procedure, and you have used a lot of and because we make our patients ambulatory as early as possible. So I would say these, except for pain and post embolization syndrome in the form of fever, which can be managed with I would say low dose, sometimes steroids and anti-inflammatory as well as anti-allergic. Otherwise, it's a pretty safe procedure. So I'm finding it a little difficult to find out, to think about any other serious complication which our patients have suffered from this procedure.
So Tarun, I think you have summed up your list of complications, or rather less number of complications, quite well. And Dr. Swat, you brought out a whole list of problems, and your analysis of the talk was really very good. I still feel, after going through listening to all the experts here, that this topic is not as simple as it looks. There are lots of things more to it. We have to delve even deeper into this. And I know we are running short of time. So at the very end, I would like to please invite our co-convener, Dr. Tomasz Urbanek, for his final comments and what he thought about both the speakers now and the comments of all the panelists, and what would be the take-home message. Dr. Tomasz, over to you.
Thank you very much. Thank you for this wonderful talks, very interesting. I think that we all learn that this is new area, new subject and new understanding of the venous disease. Probably not all patients have to be treated in the same way. We have to differentiate between those with like symptoms and signs, I mean varicose veins of pelvic origin, and those who are with pelvic complaints. I think, and that's all from my side, but if we have just 2 minutes, we have one important comment from someone who is, I think, the real hero, also in the context of anatomy and understanding of venous disease. And his name is Dr. Jean-François Wool from France. And as I had this small chat with him, he has a very important question and comment, because as we see right now in various places in the world, the people open the pelvic vein treatment clinics. And I think that this is another point that we should probably not coil all the veins that are available for coiling. And please, Jean-François, the final comment will be from you, and probably will be very critical and practical, because you see this probably from some other perspective than we. So please,
thank
welcome.
you, Tomasz. Hi to everybody, to all of my friends here. Yes, first I would like to congratulate the speakers. Very nice and very detailed topic, and very nice. I have 2 comments. The first one would be regarding reflux, and Aleksandra explained very well the anatomical connections are we have to keep in mind that the connections are a lot. There are vertical connections to the lower limbs and to the spine, and horizontal connection a lot in between both sides. And this is explaining why Dr. Tarun Grover explained very well that a very accurate assessment of all the pelvic veins is needed prior to treat, because you have so many connections that if you treat just one pedicle, you will have a recurrence in a lot of cases. So that is the first point. The second point would be regarding obstruction. I think this is not very well known, I think, but probably you know, there is another diagnosis of obstruction of the pelvic venous syndromes. Why? Because it is positional. That is, according to the spine position, you have a lot of differences between the diameter of the veins. It's good for the Nutcracker, of course, but much more for the Meissner syndrome. That is, and this is the reason why you find in women much more compressions than in men, because they are in hyperlordosis. And this is also explaining during pregnancy why you have a problem. You have compression of the vena cava, and you have also hyperlordosis. So this is explaining the compression either for the Nutcracker, because the spine is put forward, so the aorta is screening the renal vein, and also for the Meissner syndrome, because the iliac artery is also the same. So we should take in account more positional diagnosis, that is in echo, to try to, not in lying position only, and this is a problem for venography, because we are only in lying, and we can assess the patient is in standing position, and we will find very different things if we do that. And Dr. Franceschi has a nice movie about this, explaining that you have a compression, and if you modify the position of the patient, the compression is disappearing. So this is complicated. Everybody said that this topic is very complicated, and in the positional compression should be matched with the clinic and with the symptoms, and this makes the topic very complicated, because we
thank you very much
of our diagnosis. Thank you for your time and your...
Thank you very much, Dr. Wool. So another argument and another point that was raised, not only underdiagnosis, because we missed a lot of patients who comes from one gynecologist to another one with the pain of the pelvis or the complaints that are fully unrecognized, and opposite to this situation, overdiagnosis, especially in very teen young people, who comes with the suspicion of Nutcracker syndrome quite frequently right now. So, and also other compressive syndromes. So I think a lot to do ahead of us. I think there will be not decade, but decades needed to do this. Personally, I would like to thank for invitation on behalf of me and also Alex. We are proud to be here, and this was a very nice discussion, but especially very interesting course, seeing how we proceed with this patient, and also an important message that there are so many questions that should be answered that probably we can spend our life working on this, which hopefully will happen. Thank you very much.
Thank you. So at the very end, on behalf of the Venous Association of India, I'd like to thank all the attendees, especially like to thank Dr. Rahul Jindal, who has been the coordinator for this whole series of webinars, which are organized by the VAI, and he's done phenomenal work on that. Dr. Urbanek, very kind of you to accept our invitation. Dr. Aleksandra, a lovely presentation. In spite of your illness, you happen to be here, and that is something fantastic. Dr. Grover, as usual, super presentation. And Professor Mark Malouf, in spite of being more than midnight, early morning in Australia to join us at this time. Dr. Gavish from Egypt, our close friend, and our new friend from Turkey, Dr. Doganchi, who's always been with us. He was always with us even during the conference in January, and all the rest of you who attended this meeting. Thank you very much for attending. Hope to see you again soon. Good night.
Thank you.
Stay safe.